In this module, clinicians in training will learn more about the barriers immigrants may encounter when seeking medical services, as well as strategies to decrease any potential biases to improve their cultural competency over this marginalized group. Students will learn how clinicians in training can learn more about their client's cultural identity, as well as the impact of cultural competency on providing high-quality services, the effects that stereotyping and microaggressions can have on the relationship between the healthcare provider and client, how culture and stigma can influence immigrants' help-seeking behavior, how immigrants seek help for health needs based on current literature, the differences in communication styles across cultures, and strategies to reduce bias during assessment and diagnosis. As of 2018, 14% of the United States population is made up of individuals born in foreign countries, similar to Galveston's 14.2% of the population. Regarding Galveston, the foreign-born population includes both non-citizens and naturalized citizens, and also may include residents who do not consider themselves as immigrants, such as students from other countries. Out of the 14.2% of immigrants living in Galveston, 5.78% reported speaking English either poorly or not at all. Increasing clinicians' cultural competency plays an important role in providing care, as cultural competence is considered to be foundational in reducing health disparities. One of the most popular and well-studied types of cultural competence intervention for healthcare providers is cultural competency training. There are two different approaches that can be used to address cultural competence: a group-specific program aimed to improve knowledge that is unique to the focus group, or universal or generic models that encompass a greater variety of marginalized groups. Group-specific training is used to teach clinicians about a specific group's beliefs, values, and attitudes, but should be taught with caution, as it has raised concerns about leading to stereotyping or overlooking the diversity of a group. The universal models utilize reflective awareness, empathy, and active listening techniques, and target cognitive mechanisms that contribute to cultural insensitives or blindness. As the term immigrants encompasses any individual living in a foreign country, both types of training may be beneficial to clinicians in training in order to learn about each person's cultural beliefs and values. Through understanding more about their client's cultural identity, clinicians will be able to provide care that is unbiased and culturally sensitive. It is important to know how stereotypes and microaggressions can affect the therapeutic relationship between healthcare providers and their clients. Stereotypes and microaggressions often negatively affect how healthcare providers provide services to clients. Stereotypes are fixed perceptions or attitudes associated with certain groups that cause people to form judgments that are skewed. They give rise to emotions that are usually negative, biased perceptions, and can lead to microaggressions, or deniable acts of racism that reinforce pathological stereotypes and inequitable social norms. Undocumented immigrants stereotypically elicit negative emotions and more contempt, which result in a microaggressive behavior towards this group. In healthcare, undocumented immigrants often receive lower quality or unnecessarily aggressive treatments. They also experience more neglect compared to other groups. In addition, health policies have been proposed to exclude undocumented immigrants from receiving basic immunizations to preventable diseases. Stereotypes and microaggressions also extend to documented immigrants. Examples of microaggressions experienced in healthcare include being over-recommended to institutionalized care, receiving low levels of emotional support, and undergoing unnecessary invasive surgical procedures. One way culture and stigma can influence help-seeking behaviors is through language barriers. Language barriers can impair immigrants' access to and quality of healthcare, especially if a translator is needed but unable to be present. Immigrants are also often uninsured, resulting in having to pay high out-of-pocket healthcare costs. These higher costs cause immigrants to not be able to pay for the care they need, which results in the avoidance of seeking healthcare services or accumulating higher amounts of debt. Additional help-seeking behaviors include the reduced likelihood for immigrants to use primary and preventative medical services, hospital services, emergency medical services, and dental care compared to native citizens. One result of these barriers to seeking healthcare services is that low-income immigrant children are 4 times more likely than low-income native-born children to lack a routine source of care. Immigrants that are either documented or undocumented often turn to safety net clinics and hospitals that are state or county-owned facilities when they are in need of medical care. They also may go to facilities that are affiliated with charities or religious groups. By going to these facilities, immigrants are able to receive medical services at a reduced cost or even for free. Some clinics in Galveston that offer free or income-based services include our St. Vincent's Clinic, which offers free services, and the Galveston's 4 Cs, which is a community health center that provides services based on income. The reliance on these facilities has led many communities to worry about the uncompensated cost of healthcare for uninsured immigrants. Interracial medical interactions are less patient-centered and less positive than same-race encounters. This, in part, is due to how clinicians who do not speak the same language as their patients will need an alternative way to present the information in a format the patient will understand. Medical interpreters are often used when the clinician and patient do not speak the same language. However, medical interpreters may not always be present, or there may not be a medical interpreter for the language needed. Other alternative interpreters include telephone interpreting services, other available staff members at the facility, or families and friends of the patient. Patients who have family and friends help interpret information have reported high satisfaction, although these interpreters are not typically trained to accurately exchange information. When an untrained individual is translating information to the patient, they may omit, shorten, or rephrase information in a biased manner, causing an inaccurate information exchange. This inaccuracy decreases the quality of care that clinicians can provide to their patients. To provide the best quality of care to these patients, professionally trained medical interpreters should be available when clinicians are communicating with non-English speaking patients. In the past, one proposed strategy to reduce bias in healthcare was to increase the diversity of the healthcare workforce. This attempt was unfortunately unsuccessful as minority healthcare providers continue to fall victim to discrimination in the workplace. Instead of changing the workplace diversity, interventions aimed at combating bias were successful when they targeted multiple levels as well as the way individuals conceptualize their perception to marginalized groups. First, individuals need to recognize that discrimination from providers contributes to healthcare disparities significantly. Despite the epidemiological evidence, only 55% of white physicians believe that patients from marginalized groups receive lower quality of care compared to those in non-marginalized groups. This may be explained in that subtle biases are more difficult to recognize when they occur in a specific instance compared to when they occur in a pattern across a period of time. Providers are more inclined to omit signs of bias in their own personal practice. Once healthcare providers understand the effects that bias and stereotyping have on service delivery, they can focus on strategies to provide higher quality of care more equitably. Medical education may offer additional resources to combat the influences of potential bias, as well as promoting positive relations. Finally, developing new mental habits may assist in improving quality of care. Although they may not necessarily eliminate implicit biases altogether, practicing self-regulating bias can help make thoughts become more automatic and override previous biases. To summarize this module, the clinician in training should note that cultural competency is critical to providing high-quality services as well as learning more about clients' cultural identity. Stereotypes can lead to microaggressions, which negatively affect the relationship between healthcare providers and their clients. Language barriers and stigmas cause immigrants to resist seeking medical services. Immigrants often seek reduced costs or free medical services to avoid high medical costs. Communication styles can impact the quality of care as interracial interactions are less positive than same-race encounters. Strategies to reduce bias must occur at multiple levels to be effective and include recognizing and understanding the problem, completing medical education courses, and developing new mental habits. Here you can find more information about the topics that were mentioned in this presentation. Thanks for watching.